Good afternoon, everyone. Thank you so much for taking the time out of your busy day to join us today for another Ortho Illinois Power Lunch work comp webinar. We've got some great content today from Rachel Viel, one of our physical therapists, and we're going to teach you a little bit more about work conditioning, which is, I know if you're in the work comp world, something that you deal with quite a bit. Rachel, thank you very much for doing this.
Thanks, Bill. Thanks for the opportunity. And for those of you who are listening, thanks for listening to me for the next bit of time. I'm Rachel Viel. I've been at Ortho Illinois working as a physical therapist for about 9 years. My partner here at WorkRight, Rex Brown, and I used to get calls from the former director of rehab over the years asking what we were doing, because he was hearing about good results we were having and good programming we were offering. And when the Ortho Illinois Riverside facility opened about 9 years ago, it brought a great opportunity for me and Rex to work with a great group of physicians and an opportunity to see patients through their full continuum of care. So what we're going to talk about today is work conditioning and the right approach to that. The initial goal for a patient in a work conditioning program should always be a release to full-time regular duty work. When that is the goal, it's important to design a program that will allow patients to achieve this goal and resume their normal lives safely and willingly. Those are kind of important. So how this is done and what are the critical elements necessary to achieve this goal? Early intervention is key. We hear those buzzwords a lot, and the same is true when it comes to work conditioning. When conditioning a patient back to regular duty, it is best for the providers performing initial post-operative physical therapy or care to understand that function is the focus. It is important for rehab staff to be able to identify who might be a candidate for work conditioning services and when to make that transition. A good way to do this is to provide education and mentoring regarding how to prepare the patient for the continuum of care and when to recommend a referral for work conditioning. We do this a lot here with our therapists as they start employment here. A common example I'll give our therapists is the post-operative shoulder patient who is there with a comp case. At the outset of treatment, it is good to educate the patient on the plan for their care so they don't feel like the rug is being pulled out from under them. A sound approach would be to tell the patient at the initial evaluation, for a month, I'll be moving your arm. And for another month, you'll be moving your arm. And the third month, we're going to strengthen your arm. And if you're not ready for return to work, we will consider progressing you to a work conditioning program. This lays the groundwork for what the patient can expect in their recovery. When it comes to pain, it's important for rehab staff to understand that pain-free is not a realistic goal and to convey that to the patient. Pain should improve, but pain-free should not be the goal. Pain is normal for 12 to 18 months after a procedure. Most patients are told this before their procedure, but it's not something they tend to remember. And for most people, their formal care will be concluded before that 12 to 18 month mark. So to be pain-free during the therapy portion of their healing is really not a realistic goal. So function really needs to be the focus. The good thing is, if function is the focus, usually pain will improve. We also need rehab staff to be able to identify red flags. It's not uncommon for our therapists Prior to a physician recheck, they will recheck measurements on a patient, goniometric measurements, and have a patient raise their arm like they're moving their arm forward and up over their head, and they'll get to about 90 degrees and kind of make a face. And then a couple minutes later, they're doing an exercise where they're lifting a weight up overhead. This doesn't make sense. So those kinds of things need to be documented. And it's important if a therapist is seeing that from a patient in a lot of different instances, it's best to start work conditioning sooner rather than later. Orientation. It's important when a patient starts a work conditioning program to provide them with honesty about the focus of the program and the expectations of the program. This is a program about function, not pain relief. Again, this is sometimes a tough conversation to have, but if you're honest about it at the outset, I've found that things can go a lot better. And again, there's that reminder that as function improves, pain likely follows. One thing to consider in a work conditioning program is to offer some options regarding scheduling. Currently, in our program, we offer, most of our patients attend a half day, whether they're working light duty or not working light duty. But more and more we've found in the past couple of years with changes in employment, a lot more employers are wanting their patients or their workers back in a light duty capacity because they just have stuff that needs to get done. Because of that, we find a lot more patients are working full-time and being asked to do work conditioning in addition to this. For those reasons, we've made some adaptations to our program and are offering a 2-hour program. It's 2 hours max. It's an abbreviated program. I will say that patients take longer to reach their goal because our time is more limited, but it gives those employers out there an option to keep their employee working. And we all know if an employee is working, it's easier to get them back to full duty. Another thing to consider is to allow the patient to pick their schedule. In our program, we have a certain number of hours we're open, and we let patients know for the first 3 sessions, you're going to be here for about 2.5 to 3 hours, and then it's going to increase to 3.5 to 4 hours. We're here 7 a.m. to 5 p.m. most days. You're going to pick the time that's best for you to come in. The nice thing about this is it allows the patient to begin to take some responsibility for their situation. I've found in my career that by the time a patient gets to the point where they're ready for a work conditioning program, they've often spent several months feeling like a lot of the normal life decisions they had been making have been being made by someone else. Whether it's a doctor, an insurance carrier, an employer, or a case manager, the patient, as a reaction, can get a little passive-aggressive and begin avoiding making decisions for themselves. A work conditioning program is a great place for a therapist to encourage their patients to start to take control over their situation again. You don't need to stay in the job you no longer want forever. You can work on getting better, get a full release, and look for something else. Start thinking now about what you would like to do next and start laying the groundwork so that you can do that. On the day of a work conditioning evaluation, it is good to provide the orientation and planning a schedule, but it's also good to then provide some review of core and scapular stabilization concepts. Proficiency with stabilization is the key to success in a work conditioning program. It allows the patients to use their body in its strongest position, and it allows for quicker functional progression, and that also will often lead to some pain relief. It's not just the exercises on the patient's clipboard, it's how those exercises are done. Introducing stabilization concepts to patients, even though they've probably done a lot of this in their post-operative therapy, can be a little frustrating for them. We're very picky about form in our program, and those first couple sessions are really spent getting people and getting our patients comfortable with using their body the way it's meant to be used. Dedicated staff and space is also a really important element to a good work conditioning program. We often get patients who have not had success in other work conditioning programs. The story we often hear from the patient is that they had a clipboard of exercises to complete in a therapy gym where the person running the program was always treating other patients. So they would complete some of the activities, check all the boxes, and leave with little to no interaction with staff or other clients in the program. What these same patients tell us after completing our program is that while it's annoying at first, our attention to detail with mechanics and learning how to do activities correctly made all the difference. There is this sense of accomplishment that comes when learning something new, and once that happens, it's contagious. A separate space from the main rehab clinic where patients can encourage each other, brainstorm on work and insurance carrier issues is also ideal. Also, when there's a discussion of return to work goals, how to prepare for a physician recheck or a return to light duty, when we're having that conversation with one patient, everyone else in the room can hear it. And it happens over and over again. It really sets our patients and our program up for success. Documentation is another very important element in a work conditioning program. This probably goes without saying to this audience. Good documentation is essential as the information a work conditioning provider gives their referral source is important in moving the case along. Essential reports of a work conditioning note, essential elements of a work conditioning note include the following. Attendance. It's important to be consistently documenting the patient's attended visits versus the number they have approved. That way you know when you need to be asking for approval, when a physician recheck should be happening. Notes should also include lists of cancellations and no-shows. Attendance is very critical in moving a case in whatever direction it's going to go. And it's something we will go over, the importance of attendance. We go over that with our patients in an orientation. That's something any good work conditioning program should be doing. Another important element of documentation in a progress note would be to ask the patient about pain, frequency, and intensity. There's a certain way that I do this with my patients in work conditioning that I find quite effective. So we don't go down the rabbit hole of talking about pain for 20 minutes. I will ask the patient, since you started this program, are you having pain more often, less often, or the same? That's 3 choices. So I'll say that, and if they start talking and talking and talking, I'll ask again, are you better, worse, or the same? And we usually get there pretty quickly. The other thing that I'll ask about regarding pain is that pain become more intense, less intense, or the same. It's interesting to me. You often see the patient's wheels kind of turning and kind of trying to figure that out a little bit. And I would say it's not uncommon in the first couple weeks of a work conditioning program that we see an increase in frequency and or intensity of pain. This is to be expected, and patients should be warned of this at the onset of their work conditioning program and reminded of this if they report it. Again, this provides some honest conversation, and then you don't have somebody who's sore and then mad at you because you told them they wouldn't be more sore with this. The other thing we want to ask in a progress note of the patient is, are you ready to go back to your full duty job? And if not, why? How much longer do you think you need to do this program? What specifically needs to be better? What specifically do we need to work on? This, again, starts to put more onus on the patient to take responsibility for their program and their life. And I think what I find is that patients do appreciate that. Sometimes it takes a little while to get there, but they do appreciate that. Another thing to report in a progress note is functional status. How much are they material handling? Are they climbing? How's reaching looking? What specific, and this will obviously be different for every patient depending on the job that they're doing. What's the patient's level of effort? Are they completing their daily goals? Are we seeing any inconsistencies in how they're moving? Are there inconsistencies between what they're saying and what they're doing in the program? The other thing we want to address in the progress note is the plan. Are we ready for that full duty release? Are we needing more time, and why? Communication, it goes without saying that this is an essential part of a work conditioning program, particularly in preparation for a patient rechecking with their physicians. Before a doctor recheck, it is ideal that a progress note be completed and sent to involved parties. Along with sending the progress note to the doctor, it is wise for the therapist in the work conditioning program to either call or message, or if they can, stop in and talk to the doctor. This is particularly important if it's a kind of a sticky case. It keeps everybody kind of on the same page regarding progress or issues that may arise. The other thing to do in preparation for a doctor's recheck is to prep the patient. If the patient is somebody who is making good progress but is not quite where they need to be, and they're needing more time in a conditioning program, we encourage them, the first thing they should do when the doctor comes into the room is thank the doctor. Thank you for sending me to this program. I'm making good progress, but I'm still not right where I need to be, and here's why. Do you think I could have more time? It's that whole you get more bees with honey kind of mindset. If you're, how many times does a doctor come in a room and they're going to hear what's wrong? It's good to let people know when things are going well. After the recheck, it's important for the therapist to read the doctor's note, look for an updated order, call for approval, and schedule accordingly. So, with the critical elements of educating post-operative rehab staff, proper orientation of the patient to the work conditioning program, a focus on stabilization, dedicated staff and space, proper documentation, and communication with all parties, the chances of success at achieving the goal of a full duty release improve substantially. These are the critical elements we focus on at WorkRight, and our outcomes are as follows. We've been tracking our outcomes for the past 6.5 years. I know this because I do it personally. Every quarter I do an update. Our last update was at the end of June of this year. At that point, we had 83.31% of our patients returned to full duty work. 84.91% of post-op shoulder patients returned to full duty work. And our average number of visits is 16.40. Specifically to 2022 alone, 100% so far of our post-op shoulders have returned to full duty work. And 5 of those had multiple surgeries under the same claim. So we are really proud of those results, and we'll continue to focus on those critical elements of a work conditioning program moving forward. And at this point, if anybody has any specific questions, I would be happy to answer those.
One of the things that I know has come up before, Rachel, how often really should somebody be going to work conditioning? How many times a week or how frequently?
I would say currently most of our orders come to us 3 times a week, and usually the initial order is for 3 times a week for 4 weeks. I know there's a lot of adjusters and case managers out there that will tend to push for more of a daily program. What we're finding, especially with a lot more people working light duty, that 3 times a week program is a great number. It gives a little recovery between those days. And to be perfectly honest, we're finding there's just a certain amount of time or number of weeks it kind of takes to get someone from where they start to where they need to be for full duty. So really, when they're coming 4 or 5 days a week versus 3, we're finding we're just seeing people for more visits versus being able to jam them all in a shorter amount of time and have them ready. Obviously, there are differences. That's not always the case for everybody, but we're really finding that 3 times a week number is probably most effective.
We've got a question here from Linda who says, I've got claimants who allege they were re-injured in the work conditioning program. How well are the complaints documented? Often the therapists that they see have no notes indicating that there was a problem. How do you do that in the Ortho Illinois program?
We have that. We have had that happen on occasion, whether something really happened or something happened in imagination. We're very good about documenting those issues. Usually when somebody says they got hurt, they usually say a lot more that would lead you to believe maybe this is irritated from something they did somewhere else or another issue, long-standing issue that they have. As long as we're documenting things pretty consistently throughout, we're usually in a pretty good place if there's somebody saying that an injury allegedly happened during the work conditioning program. Now, things like that can happen, and it's not uncommon just because of the soreness factor that can be a part of work conditioning, or, I might have tweaked this when I was doing this exercise. We keep an eye on those things. We document them. We encourage our patients to use ice at the end of their sessions or to use ice at home afterwards, and we document that as well. And we find a lot of those things that people bring to our attention go away because they're not necessarily an injury, but more of an issue of deconditioning and feeling sore with starting the program.
How do you deal then, Rachel, with, so you've got some people who have had work injuries and maybe they've worked out previously. They've been educated consumers of what to expect from a workout or some type of physical therapy program, but you probably will also get those folks who've maybe never worked out a day in their life, and they're
Yes.
just not as educated on what to expect. How much of what you need to do in a work conditioning program is patient education regarding how to comfortably and safely push their body to improve?
I think one thing that's important is at the outset to again be very honest about how soreness is to be expected. One thing we do is we have our patient sign, it's a compliance agreement. And one of the things we talk about is everything you do is within your safe capacity. If we're asking you to do something you're not comfortable with, it's your responsibility to let us know, and we can adjust accordingly. The other thing that I think is important, because you will have those patients that are used to working out and those that have never worked out a day in their life, is that the therapist is present with those patients, particularly for the first couple weeks of their program, to kind of work through some of those issues, making sure that their mechanics are safe. They're not just kind of running through things to get done. That will usually fix some of the issues with that person that's not used to working out, is really that education. And that's something we're seeing from those patients who have not done well in other programs, is there wasn't that attention on how things were being done. And even with somebody who's used to working out, because, I mean, if, you know, I use that shoulder, post-op shoulder example a lot. I mean, even somebody used to working out, if they had shoulder surgery, and I don't know how much time it's been between the injury and the surgery, sometimes there's a good amount of time there, but then, you know, we're looking at 3 or 4 months after surgery, the whole body is deconditioned. Whether they were used to working out before or not, those people often tend to be more frustrated than the patients who are not used to working out, because, oh my gosh, I am in way worse shape than I thought I was, than I ever have been, and kind of guiding them through that is important.
What are some of the things that case managers or even the physician should be looking for as keys to making the transition from traditional physical therapy to a work conditioning program?
I think a lot of times, many times it comes down to just like that time continuum between when somebody's had their surgery and where they're at. You know, you don't want to start somebody too soon for fear of re-injuring that surgical area. Certainly, if somebody is starting to reach a plateau regarding what they're tolerating in physical therapy, even if, say, you know, they're not moving their arm nearly as well as you would expect them to, you know, 12 weeks out or 16 weeks out, sometimes we really find sometimes that change of scenery just makes a really big difference for the patient. Sometimes I think in post-op therapy, things can, for lack of a better word, get a little stale. And we often get patients who were nervous starting the program, who very quickly into the program will say, I think I should have started this sooner. So that's good information, I think.
You talked a lot about documentation and the communication aspect of this as well. One of the little bits that I've seen in notes a lot on the physician side is the patient's subjective complaints are not matching their objective findings.
Yeah.
What are some of the keywords that maybe a case manager should be looking for if you're finding that the patient's subjective complaints are not matching what you're actually seeing as far as effort or what they're able to do?
I think we use that same terminology a lot in our notes, and often will provide very specific examples, because unlike the physician recheck, we're with these people for a few hours, a few times a week. So those inconsistencies become pretty hard to mask if a patient isn't being straight about their situation. I also think being very clear at the onset of the program that function is the focus and pain relief is not, and being honest about that and committing to that helps patients, while they don't like at the beginning, I think it helps them be more honest about their approach to the program. I'm not going to lie, we can get some stinkers. That's no joke. But the good thing is they're more few and far between. And in that group therapy setting, usually if you've got one bad apple, most people would say, well, that's going to ruin the whole group. We really are finding that's the opposite. Because we're pretty honest about how this is going to go, most of our patients appreciate that and tend to kind of call each other out if there's weird issues like that going on. That group therapy concept is awesome. Those patients really help each other, sometimes in a good way and sometimes in a not so good way, but it's really one of the cool things about work conditioning.
If you have any additional questions about workers' compensation, referrals, or want to learn a little bit more about our Fast Track program for work-related injuries, we have all of that on our website at orthoillinois.com. You can call our main number at 815-398-9491. In the Algonquin, Elgin, McHenry, and Greater Chicagoland area, you can give my buddy Paul a phone call at 815-847-7088. Or email him, paul.strandquist@orthoillinois.com. Or in Rockford or North Central Illinois, you can call me, 815-847-7044, or Bill C. @orthoillinois.com. What body parts are you seeing most often for work conditioning? And I guess as kind of an aside for that, are there certain body parts that are geared for more success than others, or are some more challenging than others, or is a shoulder and a knee the same approach?
Well, obviously the exercises are different depending on the body part and depending on what the patient has to go back to, but I would say post-op shoulders are definitely our most common diagnosis. When I started doing this work back in the late 90s, it was low backs, low back, and that really has transitioned over time, and that's probably the most common diagnosis. But as you can see from our outcome tracking, I think we're just over 83% for all diagnoses and 84% returning to full duty with post-op shoulder diagnoses. So pretty similar, I would say. But definitely post-op shoulders are probably our most common diagnosis we see.
When you look at your volume, are you seeing most of your patients are post-operative, or are you seeing kind of an even number of post-op versus conservative care issues that also need work conditioning?
I would say 80 to 90% of our patients are post-operative, whatever body part that is. We do on occasion get just somebody who hasn't had surgery. We have had a couple instances of the doctor wasn't quite sure and the patient wasn't quite sure if whether or not surgery was warranted, and they sent them to the work conditioning program to kind of try things out to see in a more safe environment than returning them back to their full duty work. We've had a couple of those this year. I would say one had surgery, and one went back to full duty. So, kind of 50-50 there.
So, of course, we're talking primarily about work conditioning here, but as you are also very involved in our functional capacity evaluations,
Yes.
What are some of the things that you would document, or how do you recommend case managers or the physicians consider an FCE as they're nearing the end of a work conditioning program?
FCE is a good tool to use if, number one, the first thing is if somebody is not going to get that release to full-time regular duty. Again, that is our goal number one. If that's not the case, there's a couple of instances when an FCE can be very useful. Number one, if the patient is going back to a job and we really want to define like safe material handling restrictions or things along that line. What an FCE is not good at is defining, well, how long exactly can a person be on their feet? How many times can they climb up and down a ladder? That's really, while some FCE providers would argue that's something that they can figure out, I would say no. The other thing an FCE is very good at, if you're using a good product, and there's lots of products out there, is this is somebody where you're concerned about validity of effort. We do offer a product here at Ortho Illinois for FCE that pretty much level of effort is, that's the greatest predictor of the outcome of the FCE. So if you're not looking at that, number one, I don't really know why you'd be doing an FCE. And we've got very strong language in our reports if somebody is putting forth a good effort and if they're not. So the case can get moved along in whatever direction is appropriate.
Healthcare is changing. We say that 1,000 times a day here.
Yes.
What do you see the future of work conditioning?
Well, I think in the short term, I think we're probably going to see more and more of those patients that are working full-time and being asked to do this type of a program. And it is a challenge. It's a challenge for the provider and it's a challenge for the patient. And we'll just see how that goes. Certainly, over the course of my career, understanding that I've got to adapt and how I do things with my patients has to adapt has gotten me this far. It can be frustrating at times, but it is what it is. You just got to deal with that and do the best you can for the patients that you have.
Very good. If anybody has any additional questions, please do type those in now. We're going to give you about another minute here to get those questions in. I know how busy everybody is, so thank you so much again for your time. Just another reminder, if you're interested in our live event, Rachel will also be at our live event. So if you have any questions that you just are too embarrassed to ask on an online forum, you can walk right up to her and ask your questions. Friday, October 7th, the Marriott in Schaumburg. Again, continuing education credits. We didn't have it on here, but yes, adjuster credits. So case managers, adjusters, RNs, attorneys, physical therapists, go ahead and scan the QR code. If you have any questions or problems regarding all of this, please feel free to email me directly, billc@orthoillinois.com. Rachel, thank you very much for your time. I know this is a lot of work to put this stuff together, and I really appreciate you helping out and you putting it together.
Yeah, I appreciate being a part of this. Thank you.
Awesome. Very good. Everyone have a wonderful day. You will get an email. As soon as we're done with this, I'm going to go to my studio and try and bounce this all down to a YouTube video with some quick editing before a dinner later tonight. We'll get this up on YouTube as soon as possible. You will all receive an email in 24 hours to thank you for attending. And if I can get my stuff done, you will also get the link to the YouTube video. Everyone have a wonderful afternoon. Again, thank you so much for your time and have a great day.